I would like to thank you, the organization, for the invitation to show my work in long COVID that I've been doing for the last 3 or 4 years. Okay. So the issue that we are talking here is a small part of my investigation, that is the relation of long COVID and obstructive sleep apnea. So I came from Portugal. I'm from Lisbon, but I moved to the Paradise, to Algarve. I work in this hospital. This is in Portimão, near the beach and the river, and it was all perfect till COVID started. And so the Paradise just transformed itself in hell. Why? Not just because of COVID, because we are afraid of tsunamis, because we are near the sea. So 3 years before COVID, I was in charge of the campaign hospital for tsunamis. I'm a pulmonologist and intensive care doctor. And so we were organizing what is here, the campaign hospital, with 100 beds. And it was supposed to be like in a disaster, a climatic disaster. But then, when COVID started, we were the only one in the country that everything was prepared. So they start moving. We are a hospital. It's a it's a medium hospital, but it's not a huge hospital. But suddenly, with the same doctors, we had to increase all the wards, and we had more 100 beds in the campaign hospital, and all the patients who didn't have place in Lisbon were just go to the Algarve, 300 kilometers down. This was in the second wave. Why? Because in the first wave of COVID, if you remember, it was in 2020, and we are far away from the rest. We are the last in Europe, in front of the ocean. So we just closed our borders and, okay, it's done. The problem was everything was closed and we had to start working. And no tourism, nothing. So we opened, of course, we had to open the doors 1 year after. After we opened the doors, of course, what happened? We had the pandemic peak 1 year before, after the other countries. That was in 2021. And in January 2021, we were the country in the world with more new SARS-CoV-2 infections. It was more, in that day, I think it was the 28th of January, we have more than 16,000 new infections a day. So, we know that lots of people were dead, but the problem was just starting, because studies shown that 10 to 20% of infected people by SARS-CoV-2 might develop symptoms that can be diagnosed as long COVID. So at this time, three years after, it's time to take care of survivors. For all of us. And me as a pulmonologist, we have always the same issue. They arrive because, this is a respiratory disease. That's what they think. And so they arrive with post-COVID symptoms to the respiratory department, and we don't know what to do with them. So, first of all, we have to define what is long COVID. The first definition was in September 2020. It was the first time that the WHO classified the post-COVID-19 condition. And only almost 1 year after, the United States classified this disease. What is very important because of insurance companies, for patients, when the patients don't go to work, what do you write in the report? What is this? So it was very difficult for doctors and patients. So to do this definition, We don't have enough studies. This is just epidemiological data, reports. And so what WHO decided to do a Delphi consensus all over the world with all the doctors and health professionals that work in COVID. And so they decided, well, there are more than 200 different long COVID symptoms. But of course, this is a systemic disease that can be cardiovascular, respiratory, dermatological, neurological, and even psychiatric. So this is published in it was published in Lancet, but is in the WHO site also, if you want to consult. So let's start for the definition. So the last definition was you had to have a continuation or new symptoms. So you have an acute disease, but this acute disease is diagnosed by a test, okay? It's not just clinical. And if you persist the symptoms or you have new symptoms and they for 3 months and they last at least 2 months, then you are in the presence of a possible long COVID. But I talk about 200 symptoms, but of course we are not, there's the major symptom of all that is fatigue. Why? But then shortness of breath and cognitive dysfunction and brain fog and losses of memory. That's in the first wave for all the rest of the doctors who are here, they remember the loss of smell, the loss of taste, but in the second wave with Omicron didn't do that. So it was a change in the pattern of the post-COVID condition. But the major thing is fatigue is not the same thing that shortness of breath is not. So what happened? All the patients, they think they have shortness of breath, they go to the pulmonology appointment, and we start, if they have an organizing pneumonia, we are happy, we pulmonologists. If they have thromboembolism, we are happy also because we can treat it. But it's almost, in my opinion, and in my data, like 5% of the persons. All of that have something else that we don't know. So, what is fatigue? Fatigue means, I take this definition for the NIHS in the British Society. I think it explains very easy. So this was done for patients in their side. So fatigue means we have less physical, mental, and emotional energy to do our daily activities. If any one of us or experiment what is having COVID or under viral disease, and then after 7 days start working as hard as you did before, especially mental working, it's very difficult. So, as well as for moving around, it's important to explain for the patients that we also use energy for talking, concentration and attention, problem solving, and making decisions. And the major patients that I have in our post-COVID appointment are two kinds. Well, the patients that were at the hospital with comorbidities and they had a severe COVID and then they are recovering. But then we have middle-aged patients that are very active, or sports, or mental active, or working active, especially professors. I have a huge amount of school professors. They just say that we have like a brain fog. We want to develop our activities, and we cannot, and I don't know why. To think about that, I stay tired. So, with this, I start doing my research question and aims because I wanted to solve the problems of my patients. So the first question I did is, are there etiological factors for fatigue in post-COVID-19? Why fatigue? Because it's the most prevalent and we have to start somewhere. So this is the first break. So what I divided my investigation in 3 points. First, why post-COVID sleep apnea? First, because when I did I'm an ICU doctor also, and at that time I was 100% in the ICU, and it was very strange that in the evening they were all worse, and we were supposed to intubate the patients, but we know that the odds of being killed after intubation and with prolonged mechanical invasive ventilation were high. So with high flow nasal cannula, we maintained the patients. And suddenly, in the morning, they were better. And it was, and I was start thinking, something happens. Of course, we know that the odds of being obese is higher, to have a severe COVID. So I was thinking, maybe it's a connection. So I started, I'm going to start doing sleep studies in my patients. Let's see what happens. This is the first thing. The other thing was, do really they have post-COVID symptoms or are they depressed? But why depressed? Why? Because they are not working, because they are out of money, because we have a lockdown and they are at the house. Are they, traumatized because they were seeing pictures on TV? Is this really because of COVID or is it because of the environment? So I started studying that also with the psychiatry department. And finally, I would like to find clinical phenotypic patterns. Why? Because, this post-COVID, what is this? This is a large amount of clinical patterns that we have there. So, for what brings us here, let's talk about sleep apnea. So, we know that OSA activates renin-angiotensin and aldosterone system and the angiotensin-converting enzyme. And we know also that this enzyme is the entry receptor for SARS-CoV-2 in the cells. So there's here a connection between OSA and COVID. And then there is also a physiological plausibility for OSA being a causal factor to COVID-19 morbidity and long COVID symptoms by intermittent nocturnal hypoxemia, endothelial dysfunction. There's a low grade of systemic inflammation in OSA, oxidative stress, and also the microaspiration and the connection of OSA and cardiac dysfunction. So this pattern also, it's important for post-COVID symptoms. There's lots of studies, but I checked, but the last one and with more, and all of them are retrospective. Because this is a new disease and it was too quick and it was very, very difficult to do prospective studies and finish them on time. And so I just choose to bring here this large study in the States. I think it's the largest study. It's also retrospective. And the researchers found that between 2 years of the major COVID infections, they noticed in the medical records, especially the Americans have this because of the insurance, they have real good medical records. 9% of adults had pre-existing OSA. So what they did, they tried to understand of patients that have pre-existing OSA. So this is the pool of patients with pre-existing OSA. Then they choose these patients. They saw if in the records who were infected with COVID, and then they were trying to understand the odds of having post-COVID symptoms. And they realized that it was really a high odds, almost 70%. Of having post-COVID symptoms. So they found that the risk of post-COVID sequela of SARS-CoV-2 infection was associated with pre-COVID obstructive sleep apnea diagnosis. But I tried to do another thing. What if even COVID, it's important for the mechanism of having OSA, or the OSA being more severe because of COVID. So I started this trial, and it was in 2021, a prospective trial, and the idea was with the clinical question, an aim: is post-COVID-19 OSA an etiological factor for long COVID fatigue? So the population that we wanted was symptomatic patients with previous COVID-19. So here all the patients had any kind of COVID-19, mild, moderate, severe. Then we divided the patients that with the diagnosis of OSA 6 months after, and patients without the diagnosis of OSA. And then we were our outcome was fatigue. So we invited 12 hospitals all over the country. These were the 8 hospitals that were on time to participate. The others wanted, but they didn't have time, the clinical practitioners or the bureaucratic systems. So on time, we only had these hospitals, and the data that I'm going to present today is these bold hospitals, because I'm still waiting for the data of the other hospitals. So the inclusion criteria are adults, patients who attended the post-COVID follow-up consultation of the study centers, previous COVID-19 at least 6 months before, but with a PCR or antigen test, and persistent or new symptoms after cure criteria from acute disease. Why? This is the definition of WHO. But what are the exclusion criteria? This is very important. Why? Because we know there's lots of diseases like fibromyalgia that they have fatigue, previous fatigue. We have rheumatological diseases, and so this is important to see in the records of if they were already like that before. Heart failure, important heart failure. So then Parkinson patients, amyotrophic lateral sclerosis, of course we cannot enroll these patients. Then I exclude, and I was very criticized when I sent my papers because of that. But I know as an intensive care doctor that I have to exclude these kind of patients who were on invasive mechanical ventilation. Why? We are not going to exclude every severe patient, because in these kind of patients, almost of these patients were dead, at least in my country, because it was, they were too old, too comorbidities, and they just couldn't survive on mechanical ventilation. And the ones who survive, they were too many days ventilated, because COVID patients were under mechanical ventilation too many days. So of course they have fatigue because they lose lots of muscle. They have fatigue, they have post-intensive care syndrome because of all the medication we used. So this will be a huge bias. So we just excluded these patients. And I can tell you that there were very few, because during our study, we stopped ventilating lots of patients. We just did high flow oxygen. That's what was working in severe COVID, of course. Then, of course, the patients with persistent fatigue that was on the records, or for COPD or pulmonary fibrosis, and we already know. So, and what is different from our study on the other? We excluded patients with previous OSA diagnosis, because what we want to know, we already know that OSA is a risk factor. We want to know what's new. Anyway, we have the data of these patients, that because they are in our department, the patients who have OSA and had COVID also. So, what were our data collection methods? The clinicians who were doing the appointments, we did a questionnaire that was done by the staff of the hospitals. The OSA diagnosis was done after 6 months, between the 6 and the 7 months of the SARS-CoV-2 positive test. And we use an embleta, a type 3 study test. It were too many patients. We were not able to do a type 2 or 1. It was perfect, but it was impossible to do that. And we have the support of Lind Healthcare. They borrow us 12 devices to distribute in the hospitals and to use always the same device to have the same measure. Besides that, we had public and private hospitals. So it was a way also of the private hospitals do the exam for free for the patients. So there's no bias in that. The other thing, we use a fatigue scale, the shoulder fatigue scale. So at this point, we have more patients, but at this point, in these hospitals, the flow chart is, so we enrolled 267 patients. We excluded 55, and by now we have 212 included. If the patients who were excluded was 6% for previous OSA, 3% for neurological disease, and the others were missing data, missing appointments, and a couple of them were dead between the first appointment and the study. Then, of the patients enrolled, we found that 159 patients had OSA, post-COVID OSA, at least post-COVID OSA. If they have previous, was not on the records. So the incidence was the same of the previous study, the American study. The incidence of OSA in these patients was 75%. It was really huge. So it was almost 50-50, females, males. The middle age was 55. Almost of them have the PCR test. Only in the end of the pandemic, we start doing the antigen tests because we usually always confirm by a PCR test. The BMI was 29.4. And of course, the comorbidities, the more frequent was hypertension, diabetes. We only have 12 for respiratory disease, but was mild respiratory disease, almost of them with asthma. Heart disease, the heart disease, almost of them, we divide heart disease in atrial fibrillation, ischemic, valvular, and others. So, and we excluded the heart failure because it was one of the exclusion criteria. And we had 70.5 of psychiatric disease that were under medication and followed up by psychiatrists before in the records. So, in these preliminary results, we found a significant association between post-COVID OSA diagnosis and long COVID fatigue. But we have lots of data, and we found that we have this screening of symptoms in the questionnaire, and these patients, they all have hypersomnolence. These patients with fatigue. Now we are focused in the outcome, fatigue. So they have hypersomnolencia, but they have insomnia, brain fog, and memory loss. Of course, as we expected, is more likely to have fatigue the smokers and the patients with other comorbidities. At the end, this population, so we had 50% of severe COVID. It was I don't know if you remember the diagnosis of WHO, but severe COVID was patients that have pulmonary infiltrates and the oxygen was below 90. That's the definition. The moderate COVID is when you have infiltrates, but the oxygen, you don't need supplementation of oxygen. And mild was the other ones. Of course, we have lots of mild that I don't know. They just didn't come to the hospital. I don't know if they were moderate. They just stay at home, but it's what it is. So we have the 50% of severe patients, 34 of mild, and 16% of moderate. Why we choose private hospitals? Because, you know, I work in a university hospital, and of course, our patients are all severe. And we need to increase the sample to other kinds of severity. So that's why we recruited patients that are in private hospitals, because are there the post-COVID patients with mild disease. That's why we did that. Anyway, here we found 75% of OSA, and about the OSA severity, almost 55% was severe. So you can ask me, what do you expect in the future? Well, this is just an idea, and I want to share with you, and it's important for discussion to see what is your opinion about that. In my opinion, this is just an opinion, this is not data. In my opinion, we can divide at least in 4 phenotypes. Why? Well, the most simple one is the respiratory. Well, there's post-COVID patients with organizing pneumonia and pulmonary thromboembolism, and that's it, and they stay with fibrosis, and okay, that's fine. That's, then, after that, in my opinion also, I finished other study, but this is not the point of this talk. It's published in the SMIR this month. I think there's lots of psychological patterns here, and there's something that is going to take years to solve. And this is a mixture of all the things that I talked before. One thing that I realized that I found in my other study is I thought, oh, they have post-traumatic stress disease, they have anxiety. No, lots of them had they had before mild compulsive behavior. And then with this kind of disinfection, all these things, I sent them to the psychiatry department, and then they have this huge disease of compulsive behaviors, and they were suffering with that, with this afraid of infections. And then we have the sleep patients. That's what I think that maybe because they are, you know, this association, we have to study molecular, this kind of association. And finally, what I see is the ones usually are women, middle-aged women, overweight, that they have the sleep and the anxiety pattern, and they are depressive. So I would like to thank, you know, the doctor, the investigator that helped me to treat this data, because this amounts of data, and we were in the worry to do this presentation today on time, because the study is not finished yet. And thank you for your attention.